This case is a 64-year-old gentleman with a newly diagnosed chronic myeloid leukemia. He presented to his primary physicians with left upper quadrant and fevers for a while, and at the physical exam he was found to have like a large spleen. His past medical history is remarkable for a long QTc prolongation that is being treated with propranolol, as well as kidney disease with a creatinine clearance of less than 40 milliliters per minute. Lastly, the patient was diagnosed in 2014 with early stage non-small cell lung cancer that was treated with surgery and was complicated by pleural effusion as well thoracentesis procedures. Blood counts performed in this patient show a high WBC, white blood counts, as well increase of platelets and a decrease on the hemoglobin. Bone marrow is performed and show classical Philadelphia positive cells in 20 out of 20 metaphases, as well as a PCR of 90% BCR able ratio. His primary oncologist decided to start therapy with imatinib 400 milligrams once a day, and he's been followed very closely, trying to see if he's achieving NCCN milestone at 3 months. At this point, his PCR is 10%, and his oncologist decided to continue therapy without changing doses of imatinib. Around 6 months of therapy, this PCR go to 6%, which really is defined as a good outcome as per the NCCN milestones. It means every time that patients achieve from the 3 to the 6 months, less than 10% patient is doing well. However, patients around 9 months of therapy, his PCR start to go up and we see a BCR able ratio of 9%. 1 year after start therapy with imatinib 400, the PCR is already in 15%, which is prompt his oncologist to perform a bone marrow evaluation as indicated in NCCN guidelines. At this time, the patient still have 10 out of 20 pH positive metaphases, consistent with lack of complete cytogenetic response at 1 year of therapy. That's considered a failure. Kinase domain mutation are performed, and they are negative for the presence of any able mutation. And finally, at this time, new blood counts performed at this patient reveal a mild leukocytosis with immature forms as the differential, as well as some anemia and normal platelet counts. At 1 year of therapy with imatinib 400 milligrams once a day, peripheral blood PCR show 15%, and the doctor is perform a new bone marrow evaluation that demonstrate 10 out of 20 pH positive metaphases. At this point, this is considering a lack of complete hematological response, so it's a failure by NCCN guidelines criteria. His doctor also performed a kinase domain mutation to look for a possibility of the resistance to imatinib, but in this case there is no kinase domain mutation found. Finally, CBC show normal blood counts with normal hemoglobin, platelets, and white cells. Every time that we assess a CML patient at diagnosis, we try to really establish the risk stratification, mostly by so-called score system. In this case, I will have to say that this patient, by the criteria, by the physical exam and the peripheral blood, can be defined as a high-risk patient.